Hi, everyone. I'm Varun Jain, and on behalf of the Communications Committee of the ASMBS, wish you all a very happy 2026 and welcome to the first SOARD Journal Club of this new year. Just a few housekeeping items. This will be a hybrid format, and hopefully everyone will enjoy watching this recorded presentation and discussion, but please don't forget to participate in the social media comments discussion once this is posted. Very important, this is eligible for CME credit for ASMBS members. So please do use the QR code to log in, answer a few questions, and get one CME credit. It's a great way and easy way to rack up some of those over the year. I am really excited about today's article, which is a topic I have a personal interest in. This is expert-based physical activity guidelines for metabolic and bariatric surgery patients, a systematic review of randomized control trials, which was printed in SOARD in May 2025. I am delighted to introduce our author presenter and panel discussants who have graciously taken out time this evening to present and participate in this discussion. Dr. David Creel, he wears many hats. He's a licensed psychologist, exercise physiologist, registered dietitian, as well as a certified diabetes care and education specialist, currently staff at Cleveland Clinic, Ohio. Joining us for the discussion, we have Sarah Montel, who is the bariatric coordinator at Indiana University Health, actively involved in the ASMBS Communications Committee, IH Leadership Council, as well as the RDNC Committee. And we have Dr. Selvan Barbat, an experienced bariatric surgeon in Charlotte, North Carolina, who is also the fellowship director of their MIS bariatric program, assistant professor at Wake Forest University, and also a key member of the ASMBS Communications Committee. Welcome, everyone. Thank you once again for joining this evening. I will turn it over to our author presenter, and you can share your screen whenever ready.
All right. Thank you so much. I appreciate you inviting me. I will go ahead and share my screen. Okay, so as mentioned, this paper is expert-based physical activity guidelines for metabolic and bariatric surgery patients. It's a systematic review of randomized trials. I want to point out that I am not the primary author. I have a modest role in the paper, but Melissa Fernandez Alonso was the primary author, and the senior author, who I worked pretty closely with, as well, is Elisa American. So I want to give them credit for all of their hard work. If anyone who's done systematic reviews know it's a lot of work to gather this information and then to create recommendations from this. So the first thing I guess is an important question is when we think about guidelines or recommendations, especially around physical activity, it's like, well, guidelines for what purpose? And a lot of times we think about physical activity and in the context of weight management as well. What's the effect on weight loss? And that's an important question, but it's not the only question. And for many people, it might not be the most important question. So we have guidelines. Is this for weight loss? Is it for health? Is it for muscle? There's a lot of information right now. It's very popular to talk about muscle and muscle loss with metabolic and bariatric surgery or with the medications and their medications. What about bone health or mental health? We know physical activity has an effect. So all of these are important considerations when we're thinking about guidelines. This is not just a guide. We did not create these just for one of these. Also, I think when you look at studies, it's important to consider efficacy versus effectiveness. So if we get a group of people who say, yes, I will exercise and I will come to a gym or a laboratory and do that, we can see the effect of physical activity or exercise. But how important or how generalizable is that for our patients versus a study where we say, hey, anyone is eligible, how many people actually sign up for this study, and what's the effect when we do this kind of in people who maybe aren't as motivated. So we have a lot of things to consider when we're doing this type of work and trying to develop recommendations or guidelines. I would say I'm gonna step back and just highlight a different paper that I was a part of, and just kind of with the question, some people say, are there really enough data to create guidelines or recommendations? And some people say, no, there's still a lot that we don't know. So this paper was published, or we're working with this around the same time, um, with Julia Hussein as the primary author and Aurelie Bayou as the senior author. And the conclusions were we don't know much at all. We don't know the answers to a lot of questions. We think we know a lot of things, right? We think we know that preoperative exercise has a positive effect on BMI and 6-minute walking test distance. We think we know that exercising after surgery has a positive effect on body weight, BMI, waist circumference, bone mineral density. Again, after surgery, we can improve endurance, muscle strength, blood pressure improvements. And the conclusions were that we just need a lot more research for greater confidence in our conclusions. So like the question is, well, should we even develop guidelines when there's so much that we don't know? I'll give you my personal thoughts, why I thought it was still an important endeavor. We all make recommendations to our patients. They want to know what to do. And so I think we need to look at all of the information that's available to say, okay, what do we know? What do we think we know? But we want to talk to people who we consider well-versed or experts in the field. We also want to look at what other studies have shown outside the realm of metabolic and bariatric surgery and consider, well, what's different about the patients that we work with and how do we consider that in our recommendations? Okay, so we're making recommendations. I think programs and practitioners are looking for guidance. What do I say? We, as a registered dietitian as well, and Sarah's with us tonight, but we work very hard on, okay, what should be the recommendation? How much protein and how much fluid and what are the vitamins and minerals? Have we adjusted those over time? Absolutely. Do we adjust those individually with people? Absolutely. Do we know everything? Nope. Do we still have recommendations? Yes. This allows us to prioritize what's important and give our best practical advice. I will say that this paper is definitely not the final word on things, and we should have updates as we get more information. So back to the paper, what did we do? So we looked at 39 different articles, and this was from 24 randomized clinical trials. So obviously some of the trials had multiple papers that were published. And then the recommendations were based on these papers, the expertise of the research team, which included a surgeon, a nurse, exercise physiologist, etc. And then we also looked at general principles of strength and conditioning. So I'm not trying to look at, only if there's a paper, that's the only way we could consider this. We want to look at the literature a little bit more broadly. Oh, so my final slide, well, what did we find? What did we recommend? So if you see the letters at the end of this is the strength of the data. So A is the highest and E is more on the lower end. So you see A, that means there's probably quite a bit of evidence to support that. Okay. So begin physical activity interventions before surgery. So this is going to be the case for everyone? Not for everyone, but in general, we should try to begin this before surgery. I think there are psychological reasons. There are health reasons. There's some data to show that maybe people will do better if they're more fit in surgery. So lots of different reasons for that. Number 2, unless contraindicated, walk short distances the day of surgery. And I would love in our discussion to talk more about this with the surgeons, but obviously we want to get people up and moving after surgery. We want to reduce the risk of blood clots, etc. So unless contraindicated, let's get up and move on the day of surgery. The third one, progressively increase physical activity through activities of daily living in the first month post-op. So we talk a lot about structured exercise and exercise programs, but just getting people up and moving around. Sometimes we think about recovery after a surgery, like make sure you rest. Well, yes, we want to recover, but we don't, and we want to have rest, but we don't want to be sedentary during our recovery. We don't want to lose fitness. We don't want to increase the risk of blood clots, etc. We want to avoid prolonged sitting and decrease sedentary time. So in a similar vein, all right, but just sometimes we can move around more, but then we might spend 5, 6 hours in the evening not moving at all before we go to bed. So avoid these prolonged sitting episodes. The fifth recommendation was slowly progress to 150 to 300 minutes per week of accumulated moderate intensity cardiovascular exercise. I think this is one of the big recommendations sometimes, like how much should people do of physical activity? And again, I think it goes back to some of the points I was making earlier. Well, for what reason? You know, what are we making this recommendation for? And we look at some of the older data when we look at how much exercise people do to lose weight and keep it off who haven't had surgery. And they tend a lot of times to do a lot, right? Especially people who have maintained a lot of weight loss up through the National Weight Control Registry. Those folks are doing 250, 300 minutes of physical activity a week. Are we talking about just general health? Again, the recommendation is at least 150 minutes per week for just general health considerations. So this is kind of a wide range, slowly progressing to 150 to 300 based on those recommendations. And there's other papers showing that, yeah, more physical activity helps people maintain a little bit more weight loss after surgery. It's not a huge amount. So again, we're kind of taking into account all of those different factors with this recommendation. I will add, and we might get into this more in the discussion, but nothing magical happens when you go from 149 minutes to 150 minutes per week. All movement is beneficial. It's all on a continuum. There's no threshold for benefit physical activity. I always say that some is better than none, and more is usually better than some. We start to have a leveling off of benefit. Most of the studies, bigger studies, will show around 300 minutes per week. In addition to walking, gradually increase structured physical activity. So yes, we want you to walk around, but then the structured physical activity, or what we often refer to as exercise, we want to increase that gradually. Water exercise. So water exercise obviously can be great for our patients. Decreases the stress on the joints, especially as they're losing weight. Probably want to wait about 4 weeks until the surgical wounds have healed to decrease the risk of infection. All right, so number 8, begin full body resistance training 4 to 6 weeks post-op on 2 non-consecutive days per week. So this just falls in line with the general recommendations for fitness. Again, this gets a lot of attention. Just some of the work that we've done, we know that in general, our patients aren't doing a lot of strength training unless we're instructing them, we're encouraging them. The most likely things people are going to do after surgery is walk. And so this might require a little bit more work on a team from a team's perspective. When I've done consultations after surgery with people, what can I help you with? They're usually not saying, can you set up a walking program for me? They're usually asking me to help them set up a resistance training program. How do I use the machines? Or I don't have machines. What can I do at home? So trying to get them to 2 days per week on that. Number 9, delay high intensity physical activity and abdominal exercises for 8 to 12 weeks post-op. Again, we have to use common sense. Progression is really important. I think it's important for a couple of reasons. One, to decrease the risk of injury. Sometimes our folks in his first couple months, they're not eating very much. I've had some patients before say, hey, I'm getting lightheaded. I'm doing like, wow, you're doing a lot. Let's slow down. I'm very encouraged by your motivation. Let's slow down a little bit so that you can recover, that you have enough energy to do what you need to do. Also, psychologically, doing too much too soon may not bode well for long-term commitment to physical activity. Number 10, periodic assessments of strength and cardio fitness to evaluate progress. I think this can be really helpful for a number of reasons. One, the practitioner gets to see how the person is doing. Two, it gives our folks a chance to have some non-scale victories, especially once their weight loss slows or stops. It's like, oh, it's not as exciting anymore, but they can continue to make progress in their strength and their cardiovascular fitness. And I think it's just another way to help patients stay motivated and see the benefits of their healthier lifestyle. Number 11, continue long-term monitoring with exercise professionals in the context of health. I think anything that we do, it helps to have kind of a team. A lot of our patients have maybe not been regular exercisers for many years, some never in their lives. We have a lot of folks who were, affected by obesity since childhood, and they really avoided it. So it might take that long-term support to really help people. Also, we know once people hit their lowest body weight, the only weight their weight is going to change is it's going to go up. And for me, one area of interest is not coupling our weight loss journey with our physical activity, not always connecting the two to say, well, if I'm doing poorly with my eating or I'm having some weight recurrence, that I stop exercising. You wouldn't stop brushing your teeth. So let's not stop exercising. So having this continued relationship with exercise professionals, it can be really helpful. And then lastly, consult with a dietitian, registered dietitian to optimize nutrition along with changes in physical activity. This is so important. I kind of mentioned earlier, we want to have the energy to do what we're wanting to do. Protein becomes very important when we're talking about strength and trying to build or maintain muscle. And the dietitian, I think, also we take on many roles a lot of times, and they can help with the physical activity recommendations as well. At a minimum, providing encouragement and helping with problem solving. So those are the 12 recommendations. I am going to stop there and open this up for a little discussion among us.
Well, thank you so much for a wonderful presentation of this incredible review. It's obviously parsing out a lot of elements that remain difficult to implement and measure, which is probably why we see as much heterogeneity in any published data as we do. So one thing I noticed, it seems like a pretty diverse study group, people scattered across different states. So can you share how this was brought together? I mean, I think getting guidelines in place because there's a lot of scattered information is great, but how did this study group come together?
Yeah, so um, you know, the senior author kind of reached out to various authors, researchers, clinicians, and just asked if we would be interested in helping with developing the guidelines. So we were really, it was something I believe that she actually reached out to ASMBS at the beginning and kind of asked about this. And she might have also gotten some recommendations of some folks to reach out to. So that's kind of how it came together. And it was, it was a really nice group to work with. And I think it's always good when you have people from different disciplines. When seeing things through a surgeon's viewpoint sometimes is much different than seeing it through an exercise physiologist. That's all they've done, or the dietitian. So I really enjoyed the diversity of disciplines and even the centers where people were from.
Excellent. Dr. Barber, how do you approach this topic of physical activity with your patients? What interventions or resources can be instrumental in standardizing this aspect of care? Because I think it varies across provider to provider, region to region, center to center.
Yeah, I think this is, as you mentioned, this is probably one topic that I think is very interesting. Something I I look into this for myself, and I try to portray and project, my personal interests as well in the post-operative, exercise and dietary aspects of things with my patients. Now, we've evolved in our institution, and just seeing how our own personal institution has evolved from when I first started training here as a fellow. We had a exercise physiologist and did some fitness classes. That position kind of went away, and then we collaborated with different local gyms, for instance, to help provide discounted pre and post-operative kind of courses, classes, and so on. And and it comes and goes. It's never all inclusive. It all comes down to cost of patients, and so on. And then, time and reimbursement of hospitals and so on, which is sad to say. The surgery is the big part, and then, kind of everyone else is kind of left behind a little bit, where I think that this is extremely important. And this is a great topic, and the work that you guys have done is wonderful. But to see that there's only 29 or so randomized controlled trials on a topic where there are so many bariatric institutions in the United States and in the world that we've been doing this for decades, we should have more. There should be more information on this. And that just goes to show how much of this is neglected a little bit, where it's extremely important. And so for me, I talk to my patients about it when I see them. I know that we really do work. It's really our dietitians and our bariatricians that kind of do the 6 month and year discussion, but it's not enough. It really needs to be set aside as its own visit to speak, because there's so much to talk about from the dietary standpoint. Because you can list and everything that's been listed here, and I love the way that you kind of listed it, kind of 1 through 12 in an order that's progressive. But so many times you'll see patients say, "Well, I walk. I mean, here are my steps." And these iPhones, iWatches, they're great, but they're also a curse, because it sometimes gives people some false hope. I'm doing 8,000 steps a day. I walk around at work, but I have to tell them that is intermittent. Your heart rate needs to be elevated. You need to hit moderate intensity exercise that's designated time for 30 minutes, 60 minutes a day. That in and of itself, to describe what that means, write it out for them. What is that target for each individual person? It takes time, and we need to do better to be able to take that time for patients. And especially with the basal metabolic rate that we have, building skeletal muscle, as you had said, we walk. That's probably the most common thing that patients say that they do. But getting them to want to lift weights, do resistance training, and a lot of the studies here, many of them didn't really offer a specific resistance training workout and recommendation, and that's extremely important. Skeletal muscle has a positive correlation with basal metabolic rate, and that's how we keep patients to sustain their weight loss long term. And so there's so much to this, and as you can see, I'm very passionate about this topic too. But we need to do more. We've evolved in our institution in the 7 years that I've been here. We try. It's not enough. I've almost gone so far in our Facebook group that we have to see and poll where patients go and join a gym, and maybe I can have some time after work and they can join me. But we just don't do enough.
Sarah and then Dr. Creel, at your centers, how are you approaching just bringing this topic up with the patients at their initial visits, just to bring it on the radar, to let them know that this is an important aspect to go along with everything? Because it almost seems like at least at our program, the initial intake, what we do a good job with conveying is that this is going to be a diet change and then surgery. but the lifestyle and behavior change aspect, probably not so much. So what do you all do to stress the importance of those aspects that then tie into physical activity expectations afterwards?
Sure. I'd love to answer that. And Dr. Creel, thanks so much. I mean, I think integrated health has been waiting for these recommendations. And as you said before, we've had nutritional guidance for many, many years and really just kind of waiting to see what are those recommendations for our patients. So thanks for putting those, out for all of us here. I will say we're super fortunate at our institution. So we have a full-time exercise physiologist. We may be not many programs have that. So we have everyone do a initial assessment with our exercise physiologist. We do an in-body. We have her integrated in all of our education classes. She does follow-up. So we're super fortunate. And then we see patients at like 6 months and a year. And again, getting those body compositions on patients so they really can see their progress. And we definitely can see the difference that it makes in our program. So that's really been game changer probably within the last 2 years when we added a full-time exercise physiologist. But I'll ask Dr. Creel, I think we're not the norm. I think most people don't have that position. So I think a question that programs are going to have, and especially just within the last month, the MBSA QIP has come out with some additional recommendations. And one of the requirements is access to an exercise physiologist. So that's new. And those are requirements that are going to have to be complied with by summer. So my question is, what do programs do? I mean, I'm lucky because I have one, and we pretty much can build a wonderful program. But what do the programs do that don't have that? And they might have a part-time dietitian, or they don't have those resources. How can you make that work?
Yeah, it's a it's a great question, Sarah. I think it depends a lot on where someone is located and the resources that if someone's in that inner city in a surgical building, and there are some limitations in that where someone is maybe in a more rural place and they have. I think it depends on a lot of different factors, um, but I think whether it's as you mentioned earlier, like connecting with programs that are already in place, commercial programs or YMCA's or people who can be affiliated. I think that's always an option. I think if you can have the budget to have someone on part-time or full-time that understands the patient and kind of can integrate with the team, to me, that makes the most sense. And I think having that person kind of in-house where they can talk to the dietitian about a patient. They can work with the psychologist to say, hey, this person really is struggling with body image. So when you say go to the pool, we need to do some more work, or we can have that conversation about getting that person through the pool, or maybe we're not going to start at the pool, but that's a longer term goal. So I think integrated as much as possible. If not, we identify some other programs that we can help kind of um, inform or educate about our patient population, so that everyone does have not just access on paper, right, to check off the box, but it's actually helping our patients. The other thing that I think is really important when it comes down to this is to, in some way, ask our patients, are they getting what they need? And if not, what do they need? Where, I know that you've done a lot with support groups. This is a nice forum to kind of hear from our patients so that we're not just kind of guessing what they need, but we're actually hearing from them, so that we can design things in a manner that is truly most helpful to them.
Um, uh, Probably, actually, probably a question for everyone, but Sarah, as coordinator for the practice, I'm sure you see time and time again, socioeconomic factors tend to become a major barrier to just the so-called healthy diet and lifestyle habits that we recommend so often. So at least in the context of physical activity guideline implementation, what are ways to overcome this, especially if there's no in-house specialist at majority of the places? I'll tell you, for example, our institution, big academic center, but we don't have an exercise physiologist. And in my training also previously, it was probably informally part of the education provided, but not a formal person dedicated to it. So access to equipment, access to the education, the time dedication needed for that appropriate education and follow-up when we're usually trying to, get through visits. I have to say, I hate to say it, but I mean, that is the reality. How do we overcome some of those barriers?
It's very hard. I think it's hard for all of us, and I think it's prioritizing. I think it's coming up with, like, as Dr. Creel said, coming up with those resource lists. What are, if there's nothing in house, here's some lists. We have dietitians, and I feel like our dietitians do so much work in all different areas, but coming up with, hey, here's some fitness like websites that you can go, and we really need to look at credible websites that are not just random people on TikTok or random, so what are the specific things that you can do? What are resources and credible things that you can do from your home? Really working on virtual visits and virtual connection, because they aren't going to come. I mean, I think we all have to work on that, because even if they're not coming back to us, what are the resources that we can provide in their outside community? And that's with nutrition, and that's with fitness, and that's with, everything. So it's taking that downtime to provide all of those resources, so then you can have those for patients. I don't know, Dave, you
Is it?
probably have a lot more thoughts on that as well.
No, go ahead.
No, I think that's great. I think we have to meet people where they are. And a lot of times that is in the virtual setting. And I think the one thing that sometimes we forget about, it's like, okay, we want to optimize our recommendations. And I kind of hear this a lot. But truly, we want to optimize engagement from our patients. And so I think trying to make this appealing to our patients is really important. How do we make physical activity more enjoyable? And what can we do in that process? Some of it is kind of an internal thing. We have conversations with, what you can do to make your bout of exercise more enjoyable, but also what kind of communication do we have? What kind of programs or services are we going to offer that can make it more enjoyable? Even, movement probably hasn't been enjoyable for many of our patients. So I think that's the one aspect. Like if I were writing kind of psychological recommendations, right? One would be to really try to make physical activity more enjoyable, to listen to our patients and develop progressive types of recommendations, even if they're not meeting, 150 minutes a week. If they're doing nothing and we get them to do 10 minutes 3 times a week, we're making progress. So yes, I think we have to meet people where they are. We have to provide as many resources as possible. And I think as a team, kind of be on the same page that, yes, we're going to give our patients credit for anything that they're doing that's kind of moving in that direction.
Can I ask a follow-up on that, Dave? Because I think that's
Yes.
super important. That I think we can get stuck on that 150 to 300 minutes. And you mentioned it's not, it's not super concrete. How do you communicate that to patients? So, you have someone who's not doing much, and then we have these guidelines that say 150 to 300, which can be so overwhelming. What's the best way to communicate kind of what you just said to patients?
Yeah, I think there are a couple of steps. One thing I will do a lot, I will ask people, tell me again why you decided to go through this procedure, right? And so, they'll talk about just, wanting to have more energy. They'll talk about wanting to be able to do things with their kid, not sitting on the sidelines, whatever it might be. And I really tried to connect that to the physical activity, to say, this is not something separate. This is something that will help you reach those goals. Or I try not even to say that. I say, do you think these types of things would help you in that area? Get them to say it, right? So that's one aspect. The other thing is sometimes I will actually show them. I have a group. We have a group called Reboot for people who have had weight recurrence. And I show a slide of, I could have put it up in my slide set, but of a review paper looking at step counts and looking at all-cause mortality and cardiovascular mortality. And it's really interesting to see that when people go from even like 3,000 to like 4,500 steps a day, how their all-cause mortality based on this research goes down significantly. So when we get people who are sedentary to do more, do a moderate amount, that's probably where we're getting the biggest health benefit, is when we get people who are sedentary to be moderately active. Is there ongoing increases and improvements in health? Absolutely. But just to say, hey, if we can get you to do some more, it's really going to help you. Now, with some of these other lifestyle types of things, well, what are you wanting to accomplish? If you're wanting to sightsee all across Europe and you're going to be climbing steps, that's more of a fitness than just health type of thing. So there's kind of this continuum. So talking about health, their health goals and their fitness goals, and kind of making it progressive based on that. I don't know if I answered your question.
You did. That's so helpful. Thank you very much.
Dr. Krill, I have a question for you. Looking at the guidelines and the evidence here, only a few of the studies had demonstrated that you should work out or have a physical activity kind of regimen before surgery. As we know, a lot of patients have the surgery, expect the weight loss to occur. And we're talking about habits, having both a background in psychology and having a background in exercise physiology. Habits, it's hard to break habits. It's probably easier to break them just for the short post-operative period, and then life happens again. What would be your recommendation for patients and for programs of timing wise and how to try to start those habits early on? How early is too early? And how do you get patients to do that before surgery?
Yeah, it's a good question. There are some of the patients that you see, it's like, wow, they're going to be able to move so much better once they lose some weight. It's really hard for them. But I think getting everyone kind of engaged, it's kind of an exciting time too, right? Sometimes we can get people to do really tough things before surgery, like to qualify for surgery, right? But I never want it to feel like a threat, but to say, hey, you're wanting to put this process in motion. What can we do right now to get started? It can be as simple as chair exercises, or it could be like doing push-ups against the wall. I mean, something very small. A lot of our folks now have wearables, and I'm a big fan of using the wearables to say, okay, you're getting 3,000 steps today. What do you think about getting four? What would you have to do to get four, right? And I think that sometimes gives people confidence. Or every once in a while they'll say, "Oh, I went shopping and I got 8,000. How'd you do?" "I was a little tired, but are you doing okay with your knee?" "I was doing okay." So that tells me that your body can maybe handle that. And so we kind of promote that. So I'm a big fan of the wearables, chair exercises for people who can do it, finding a specific time of day to carve out for them to do it. So again, this is kind of psychological, but to say, hey, when's going to be the best time for you to do physical activity? They say, well, I have time in the morning. But we don't start with 30 minutes in the morning. Let's set aside that first 10 minutes for you to maybe do some light chair exercises or maybe some stretching or walking in place or a short video. So we get the rhythm in place, even though we're maybe not getting huge benefits, we're setting the stage to get the longer term benefits because we're establishing a pattern.
I will say I agree 100%. I don't know about how early is too early. At my first visit, I usually will tell the patients that you'll hear a lot about the diet and lifestyle change, but one thing to start working on is the physical activity. And I try and use just the simple words where I say structured activity, 30 to 60 minutes a day, 3 to 5 times a week. And in their mind, hopefully it reduces the burden of thinking about that in addition to everything else, which I do feel can become overwhelming for a lot of people. And what I usually try and tell them is that people that start these early on are more likely to continue it afterwards. And the one thing I do use, and it's partly not with the intention of scaring them, but I do think it's a real expectation, is during periods of rapid weight loss, we know that people lose fat-free mass loss. So the lean muscle loss is there. Now, when there's lean muscle loss, there's decreased energy, decreased metabolic rate, decreased activity, or decreased energy levels, which then promote inactivity. Inactivity further leads to muscle mass loss and becomes a negative reinforcement cycle. So I usually try and tell them that if we can keep the muscle mass intact with proteins, the diet part being the building blocks, working the muscles is what will keep the muscle mass intact. And if we keep that intact but lose weight, increased energy levels, increased metabolic rate, more energy, more likely to result in more activity. So positive cycle. So it seemed to work well with a lot. My question is, Dr. Barbat, you brought up the heart rate and the moderate intensity exercises. Dr. Creel, you mentioned wearables. Heart rate monitoring now, I feel, is fairly simple and inexpensive. So, how often do you end up encouraging patients to use that as a guide and consciously monitor the zone that their heart rate gets elevated to?
Good question. I'll be honest. I don't use this a lot with our patients. One, because we know the research sometimes when we look at like the heart rate zone and kind of what you and I might work out and feel like this is moderate. A lot of times that heart rate for them, it doesn't feel moderate. It feels vigorous. The other thing sometimes is, if they're on a beta blocker or something like that. So I'm not saying I never use it. Sometimes I will use it to say, hey, check it because it sounds like you're working pretty hard. What was your heart rate? Like, is it too much for you, right? To kind of help them kind of enjoy the exercise a little bit more, at least initially. Now, if someone's a year post-op and they're training for something, they're doing intervals, and that's a different story, but that's not the majority of our patients. So I use more things like, how hard does that feel to you? How's your breathing? Can you carry on a conversation? Can you talk but not sing? On this scale, on a 1 to 10 or a 6 to 20 art rating of perceived exertion scale, where is that for you? Oh, it's moderately hard. Or even if it's light, I'll say, you're still getting benefit from it. What do you think about going up? So what we know is that the enjoyment of physical activity, once we hit ventilatory threshold, which is when our respiration's going up faster than our heart rate, pleasure goes way down. Unless you're that person that says, I just love a challenge. I love to say I got it. Most of our patients aren't there, right before surgery or right after surgery. So I don't use it a lot, to be honest with you. But it is a tool. It's an effective tool, I think, to help people kind of see. The other thing I think we can use it for is things like resting heart rate. As you're doing the training, what's happening to your resting heart rate? So people can start to see progress in that regard as well. And I don't know if you guys have different opinions on using the heart rate. I know not all physiologists would probably agree with me, but I think there's so much variability within our patients and how they experience it, even if they're in both their zone.
Yeah, I think I agree. So, especially in the patients that are just starting to get through their exercise regimens. A very little effort could spark a pretty high heart rate and effort for them. And so probably in the later phase in your algorithm and guidelines, that would probably be more towards the 10, 11, 12 when you're starting to look for physical activity, high intensity activities, maybe a good tool. I did have a question for you. I've noticed with patients trying to get them through and both from a behavioral, psychological, and kind of socioeconomic kind of path, I've noticed certain types of trends of types of people, introverts, extroverts, I work too much, I just don't have time, or I can't get out of the house, or I need a buddy. Kind of, how do you kind of decipher these patients? Do you have kind of in your mind groups of types of patients, and do you have different recommendations to get them more motivated and involved in physical activity?
Yeah, it's a really good question. I kind of as you're talking, I'm thinking about what we're talking about is kind of tailoring our interventions to the needs of our patients. And I think as much as we can, we want to provide resources from a programmatic standpoint or how people can do this. But to your point, some people really like exercising in groups. We've been working on, I just recently finished a little pilot study that hopefully will get published, but developing an assessment instrument. And we looked at different factors. So social support being one of them. Do they have adequate social support in their opinion? Kind of their beliefs about exercise, their beliefs about themselves, their limitations. So many different factors. Then we created a report for them. These appear to be your strengths, your challenges. This is some of the things that are intermediate, and then providing interventions and feedback based on that. So I think many times, like I said, we get really big on saying this is the recommendation that we want you to do without asking some of those really important questions about when you've done exercise in the past, what was that like? And did you enjoy it? Okay, that gives us a really good clue about maybe what we can do in the future. It's like, that class disbanded because the gym closed. Okay, maybe we look at something else that they can do. So I really love the idea that you're bringing up with really trying to understand the patient and then tailor our intervention, not just tailor our exercise prescription, but tailor the action steps to get them moving more, to, engage with somebody else, to be part of a group, to go to a class, to do some home exercise. Oh, the videos. Do they like technology? If they like technology, they might get a really nice smartwatch. If they're not big into technology, I had one guy that I worked with that he just had his old school calendar, and he said, I got so much satisfaction if I put more X's on the days that I exercise than I didn't. I felt a lot of satisfaction. I'm like, that's perfect. This guy's like, he's doing his own self-monitoring. He saved $200 on a smartwatch, but that was his idea. Like I just put X's, and that was kind of how he was wired. So love the thought, and I think we need to do a better job of looking at some of those psychosocial factors and trying to tailor our interventions based on those things.
I wonder
Doctor,
if anyone's ever done like a buddy system or a sponsor or a mentor mentee for really successful patients that are just killing it on the physical activity dietary and kind of take on somebody as a big brother big sister kind of thing and see if that does help patients.
Yeah, I haven't seen a study. Sarah, have you guys done that at your center? I know at our old
yeah,
center we had something. We had like
yeah.
a buddy program. Yeah.
Years ago, we did a mentor program where we'd match up like the more successful patients with people that were struggling, and it worked. It worked very well. It was a lot to manage, but we did see definitely a benefit. But I like all your ideas on tailoring, and we don't really do a lot with heart rate because again, they're tracking protein, they're tracking calories, they're taking their vitamins. Sometimes it's like one more thing. Um, Quick question, Dave, just for you. So if you're a dietitian and you have a 20-minute appointment and you need to cover vitamins, diet advancement, all of the nutrition things, and then the last box is are you exercising? What are some quick things that you can do in that appointment you know, to motivate a patient or assess a patient, or what are the things if you just don't have lots of time to do it? Quick snippets, I
Yeah,
guess.
yeah. It's a good question. I know time is always the factor. I think as much as possible, sometimes we have our agendas and sometimes we have a little bit of a checkbox. But I always try to start, at least early on in the session, how can I help you today?
Hmm.
So that kind of helps me think about what's going to be most important to them. And in the same vein, like um, if you ask them, how's it going with your physical activity? How can I be of help? I think asking that question, sometimes I have a question that I ask, like, what can we do to help you most with your physical activity program? And then sometimes I have like three things. Do you need more support and encouragement? How would you rate that? Do you feel like you need some more testing, or do you need more knowledge? And as a dietitian, you can say, okay, I can provide the encouragement and support. If they want more knowledge, that's maybe where I refer that to the exercise physiologist, right? Or testing. That's where I refer that. So maybe having a little bit of a template in that
Yeah.
way. But I think it always, to me, it narrows things down when I ask the patient what I can do to help them most. They might not always know, but then you're building that rapport so that in future endeavors they want to come back and see you because they've had a chance to kind of express their needs and wants.
That's a great point. Thank you so much.
Sure.
Last closing remarks with these guidelines now, understanding that they are guidelines, but at least some structure around it. What is the opportunity for incorporating some of these categorical recommendations as part of the initial education material that I'm sure all programs have that are provided to the patients?
Yeah, that's a good question. I haven't really thought about that. But I think, this could be a page that these are published. Yeah, they could just be 1 through 12. And you could then get some feedback from the patient. How are you doing in these areas? Like if it's, I guess it's a before surgery, you're not going to have all these things, but you could ask them how they feel about these things. How do we set a path forward to help you do that? You could even break these down. I know sometimes in materials you kind of say, oh, this is where we're at diet progression, and you've got 8 to 12 weeks. Now you've got this alongside of it. So you can kind of maybe couple these with some of the other recommendations. Might be a way to do that. I don't know. You guys might have some other thoughts, Sarah or Dr. Varda.
Yeah, I think it's a great thing to. I mean, it seems like it's very simple. I agree. Just a little page that can be added on both at the initial consultation as well as your 1 to 2 week follow up, 3-month follow up, and so on. Is a constant reminder, and sometimes as you said with the calendar, is sometimes maybe create a kind of a checkbox kind of thing for it to kind of make it an activity for people to do. I think would be a very easy to do, very easy to visualize with few words, so that people can really capture it without getting bored.
Yeah, I agree. Our exercise physiologist, again, full time, so we're pretty lucky. So she's integrated in our first like educational class where we talk about the benefits, several slides about that, encourage a visit. She's involved in our prep education class. She does 3 exercise classes a week. I know you guys are all jealous, right? And she runs our social media. So, I mean, she's always posting motivational Mondays and different fitness, So again, we're lucky. Not everyone's that lucky. So here we are. But I think as much little snippets that you can get all the way through your program is going to be helpful. And I think it's a challenge. So that's kind of why I asked the questions about dietitians. So we can do that as well. So if you don't have that luxury, how can other people kind of integrate it into your program? Which I think those were great tips that you gave.
And I think now that these guidelines are out and it puts, you guys have done the work for everyone and put it right there for us to very easily see and follow. Now we need long-term outcomes and how this makes a difference. And so I'm hoping people watch this, and in the next 12 to 24 months, we're at ASMBS with someone presenting an abstract, looking at outcomes in a structured program versus not controlled, based on these guidelines in a year or two, because that will just reinforce what we tell the patients. This works. Here are the differences of those that do it and those don't. So I really do appreciate the work that you and the authors have done on this, and now I hope everyone takes it and uses it and studies it, because we do need more data on this.
I agree, 100%.
All right. Well, we are approaching time to wrap up. I just want to sincerely thank you all for making time this evening, hang out, participate in discussing this wonderful paper and topic. I do invite everyone to please participate in the moderated comments discussion when this recording is eventually posted on the ASMBS social media page. Please call out to friends, colleagues, have them share experiences, suggestions, ask questions, even if they're controversial. We love them. But we look forward to a robust, extended discussion offline. But thank you once again. Please, everyone, have a wonderful rest of the evening.
Thank you.
So much. Have a good night. Bye.
Thank you.
See you.